Alcoholic delirium tremens is the most dramatic withdrawal syndrome. It usually starts 2 to 3 days after drinking stops. On average, the syndrome lasts 3 days but may continue for much longer. Without good supportive care and adequate treatment, delirium tremens is associated with significant mortality. Risk factors include long history of heavy alcohol use, previous history of delirium tremens, and also concurrent illness, significant alcohol level during withdrawal, long duration since last drink as over 48 hours, and age over 30 years. Causes sudden withdrawal of alcohol from a long-term chronic user of alcohol. The symptoms are restlessness, shaking of hands, whole limbs or body, sweating, confusion, inappropriate behavior, unintelligible speech and disidentification, seeing or talking to imaginary objects. Signs that are usually elicited are tremors, psychomotor agitation or retardation, sweating, vomiting, disorientation, intermittent visual, tactile, or auditory hallucinations or illusions. Visual hallucinations are frequently of small objects or frightened animals on walls. Also, fever of more than 38 degrees Celsius and pulse more than 100 beats per minute and blood pressure more than 160 100 millimeters mercury. Investigations, full blood counts, liver function tests, and screen for malaria and common infections. So the main treatment objectives are to relieve agitation and calm patients, to correct fluid and electrolyte imbalance, to prevent complications like seizures, development of amnesia and encephalopathy. Also to prevent or manage heart complications if present. Non-pharmacological treatment, seclusion of the patient, application of restraints as necessary, psychotherapy and psychoeducation. Pharmacological treatment, as for control of seizures, we give lorazepam IV or IM or even oral in adults days 1 to 3, if 2 to 4 milligrams once daily, and days 4 to 5, give 1 to 2 milligrams once daily. Or you can give diazepam IV, administer slowly over 2 to 3 minutes, approximately 2.5 milligrams every 30 seconds. In adults, day 1, you give 10 to 20 milligrams 6 hourly, day 2, 10 to 20 milligrams 8 hourly, day 3, 10 to 20 milligrams 12 hourly, day 4, 5 to 10 milligrams 8 hourly, day 5, 5 to 10 milligrams 12 hourly, and then stop. It's best to give benzodiazepines as needed rather than on a fixed dose schedule. Withhold if patient is asleep or has slurred speech, ataxia, nystagmus, or oversedated. Could also give chlordiazepam oral in adults, 50 to 100 milligrams 4 hourly as required, with a maximum dosage of 300 milligrams. And then you give timing oral IM or IV in adults 100 milligrams daily for 3 days before any IV glucose load. And then you give folic acid oral in adults 1 milligram daily as needed. Then you give dextrosaline 5% glucose in 0.9% saline IV, and then adults as necessary. For patients with seizures not controlled by benzodiazepines alone, We give lorazepam IV IM or around in adults from days 1 to 3. We give 2 to 4 milligrams once daily. Days 4 and 5, we give 1 to 2 milligrams once daily. I can give diazepam IV, administer slowly over 2 to 3 minutes, approximately 2.5 milligrams every 30 seconds. Adults, day 1, 10 to 20 milligrams 6 hourly. Day 2, give 10 to 20 milligrams 8 hourly. Day 3, 10 to 20 milligrams 12 hourly. And day 4, 5 to 10 milligrams 8 hourly. Day 5, 5 to 10 milligrams 12 hourly, and then stop. And you give phenobarbital slow IV or IM in adults 0.5 to 1.5 milligrams per kilogram 12 hourly. Referral criteria: to refer patients whose symptoms are difficult to control within 3 days, or who remain agitated despite being given over 20 milligrams diazepam within 4 hours to a specialist. And refer patients to a psychiatrist or clinical psychologist for consideration of other treatment options to assist long-term abstinence and rehabilitation after acute phase is over.